Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri,
And I'm Andrew Sanchez.
and we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So, whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
It's like lazy here. I don't know if you can see my dog because I think the camera.
Oh, yeah, I can.
Yeah, he's like, yeah, that's the vibe for the morning.
Stage right.
Yeah, he's just chilling. We'll put his little rain jacket on him this morning to keep him dry. So cute.
That's very, very cute.
You want to get into it?
Let's do it. Yeah. All right. So this is a 50-year-old gentleman. No major past medical history, hypertension, hyperlipidemia, both well controlled. Sees a doctor if once a year, maybe not even every other year. He's coming into your emergency department with about 3 days of epigastric abdominal pain. And he's found to have elevated transaminases. So, and then I can give you more, but I'm just going to start there because I think I'd like to hear your thoughts on sort of how to approach this problem. So he comes in, his AST is 985, his ALT is 2611, alk-phos 278, T-Billy is 8.1, direct is 6.4. And I can give you the other labs as well. So he's sodium of 131, potassium 3.9, normal chloride, mildly low bicarb at 19, no gap. His renal function is a little bit decreased as well. He has a baseline 0.8 creatinine, it's 1.1, normal glucose. His CBC is notable for, it's unremarkable other than a very mild thrombocytopenia at 144. And the lower limit of normal for this assay is 140. So it's kind of borderline, actually. His vital signs are stable, although he describes intermittent fevers. We don't capture a fever in the emergency department. And I'm going to stop there because I feel like there's a lot of different tests to order, history to ask.
Yeah, lot to chew on there. And
Yeah.
what did you say the Billy and the alk-phos was? I was totally like computing as you were giving stuff, but what was the Billy and the alk-phos?
Absolutely. So the T-Billy is 8.1, the D-Billy is 6.4, and the alk-phos is 278.
Got it. Okay. Yeah, so, the guy originally came in with abdominal pain. Oftentimes up front, those are very hard cases to solve before you get objective data like this. But if you do have a result, as we're seeing here, a lot of signal inside of the liver, I think the problem space becomes much smaller and easier to solve. So I think we should latch onto the abnormal LFTs you provided in the form of the AST, the ALT, the bilirubin, and the alk-phos. And people often stratify those issues into two buckets, one being more of a hepatocellular injury pattern where what predominates is the former, the AST and the ALT. And then for the latter, it's really the alkaline phosphatase more so than the bilirubin that defines cholestatic liver injury. And then if you see both, you can, of course, calculate this R index, which is this kind of objective way that hepatologists try and neatly categorize these things. But in real life, nobody really does that. And they kind of just eyeball the numbers after seeing many cases and combine the two. But I would say anytime you see transaminases in the thousands, that's very helpful. And it's, to me, this is more of like a acute hepatocellular injury type picture when you start seeing AST and ALT that high. So I'll take that frame for this patient. How to think through acute hepatocellular injury. the way I've come up with, which I actually did back on the Klatskin servers, like in a overnight call room when I just had some spare time, I came up with a buckets approach, but that is also sequential in a way, just to make sure you don't miss some can't miss etiologies for acute hepatocellular injury. So the three buckets I have are three P's. First pass being plumbing, second pass being pregnancy, and third pass being parenchymal etiologies. So I put plumbing up first because the very first thing many people think of is congestive hepatopathy, ischemic hepatitis as a can't miss etiology. Usually this is obvious in like post ICU patients, but the one thing you don't want to miss is occult cardiogenic shock, because those patients have a normal blood pressure, but will still have a very ischemic damaged liver. And then you can think of like outflow of the liver, but Chiari as well. But then what else goes like inside and outside of the liver? The biliary drainage. So I think that was for me like a forgotten cause of acute hepatocellular injury, because in med school I kind of thought, if you have a biliary obstruction, you're going to see the bilies go up, you're going to see the alkalosts go up, but really what goes up first actually in acute biliary obstruction is the AST and the ALT. If you have a fully wedged common bile duct stone, that will cause a lot of back pressure to the hepatocytes, which will then necrose off, and it'll cause a very rapid spike where the AST and the ALT will peak very quickly up to a point and then come down very quickly if that back pressure is relieved and a stone passes. And later on, if that stays wedged, then you will see the bilies go up. And then finally, the alkaline phosphatase takes some time to synthesize, and you'll see that go up. So that's the plumbing story. Pregnancy, I put that second just because, again, this is another kind of forgotten bucket for liver disease. It captures some endothelial stuff like HELP syndrome, and a couple others. And then for parenchymal etiologies, I stratify that into toxic metabolic issues versus infectious issues versus autoimmune issues. But without talking about all of those things, I would say if a patient like this came in with acute epigastric pain and we're seeing a signature here in the LFTs, the very first thing that comes to mind, just system one type thinking here, is perhaps a gallstone pancreatitis, also causing some proximal consequence in the liver in form of CBD obstruction. So I'd be getting an ultrasound to start on this patient. And I guess just to say it out loud, because I haven't, the degree of the elevation here is really, really helpful. The other layer onto the schema I just provided is I basically have like asterisks on all of the things on my long list of causes of hepatocellular injury that cause transaminase elevations in the thousands, because it's a pretty narrow list. So if you get that clue, it's really, really helpful. So the asterisks I have, acute CBD obstruction, which is the forgotten cause. A lot of back pressure can do that. It's a very rapid peak. Ischemic hepatitis, drug-induced liver injury like Tylenol overdose or anything else that can cause a massive DILI, and then viral hepatitis. Those are really like the four by far most common causes of transaminases in the thousands. So I think this guy's story like fits an acute CBD obstruction. Next steps for that, the ultrasound. If you see biliary ductal dilatation, I think you probably have your answer. If you don't, I think probably our job isn't quite done. It's not the most sensitive thing in the world, and we would probably have to get an MRCP after that if we miss something, just given the story already sounds very consistent. I think other things you could send, the lipase, we don't have a lipase yet, that would be supportive of a gallstone pancreatitis. And I think it would also be fair too, if you give me a CT, that would also be completely fair too, just because many people with undifferentiated abdominal pain just kind of have that at baseline. But yeah, what did you do for this guy next?
Yes, you actually get all three of those studies. So basically, he gets an ultrasound, which is negative. It really only shows a little bit of perihepatic fluid, not even really ascites, just some fluid right around sort of in the liver capsule. And then a CT scan is obtained, which shows actually an edematous pancreas, liver, and gallbladder. And there's a question of pancreatitis. He also gets an MRCP, though, which is negative for cholestatic etiologies. actually also negative for pancreatitis on that more sensitive study, and no, sort of like just hepatitis is the call on MRCP. A lipase is 150, and amylase is negative. And I think if it's okay with you, I'm actually just going to give a little bit more history and give you a chance to ask more questions. But I feel like, as you said, sort of common things being common, it was good to have that data up front, and then we can dig into the other stuff. So, like I said, 3 days ago, this pain sort of started acutely in the epigastric region, doesn't radiate anywhere, not noticing that it's worse or better with food, really not noticing that it's worse or better with anything other than just laying down and not moving, relieves some of the pain, and activity, moving around, using the abdominal muscles increases the pain. He has an interesting kind of social history and life history. So this is a gentleman actually who lives in the woods. He lives in a cabin that he built himself with no running water. He basically uses a stream that runs by this cabin not too far away as his means for drinking water, as well as water for making food and water for cleaning and showering, bathing himself. He basically takes big jugs down to the river, gets water, and then brings it back, and that's his water for all of those necessities until he goes down and gets it again. He noticed recently that there was sort of a big rainstorm and the river was running brown rather than sort of clear, but he grabbed some water anyway and boiled it. And interestingly, he actually noticed that when he boiled the water, there was sort of like some smoke that came off of the water, and he actually like had a kind of a coughing fit and then vomited, interestingly. And he has a pet dog. He interestingly also basically only eats meat that he catches. So he eats and he kills and eats deer and black bears. That's how he lives. He does know that there's mice in the house, and they do sort of urinate throughout the house. He's had one partner with whom he's sexually active with, a female partner. He's exclusively heterosexual, so only with female partners in the past. He uses iron cookware exclusively. And he does have a remote history of what sounds like alcohol use disorder, if not just heavy alcohol use itself. Has not drank in the last year and is pretty adamant about that. He does not use medications. He does not use anything over the counter. He doesn't believe in pharmaceutical medications, and he does not use any drugs, specifically no cocaine, no marijuana, and no IV drugs. No travel out of the country recently. And I will stop there. So you have some imaging that was really just showed hepatitis and not the other things that you were thinking of in terms of cholestatic etiologies. And then this very interesting social history.
Wow, that's such a fun aliquot. And just for the listeners, I'm assuming this is around Connecticut area. This is where this patient resides ish.
Actually, no, he lives about 200 miles north. So much more north in
Okay.
New England. Yeah.
Okay, got it, got it. Wow, so interesting. So, first impressions, yeah, what I was expecting to find, Gulfstone is such a good story. I think we fully exonerated that, and I think you all did a really good job at exonerating that. Because as I was saying, if you have a pretty high suspicion for it, the ultrasound isn't the best test, and it's like half of the causes of gallstone pancreatitis. So it sounds like you all did your due diligence and really made sure he didn't have that. But wasn't expecting to hear that the pancreas actually looked good on the MRCP, and that actually is very helpful. If the pancreas looked good on that very sensitive study, then now we're like solely on the liver now. It doesn't sound like this guy is having any symptoms compatible with occult cardiogenic shock, like no dyspnea, he's mentating well. It's just not that kind of story. So honestly, I'm like not even thinking of plumbing issues anymore. He's a male, he can't be pregnant. So now we're just like, what can cause parenchymal damage to this degree? And you already gave us his pharmaceutical history. So in terms of a Tylenol overdose, unlikely, but I'm sure you all sense the test to be safe, as we all do, just because it's low hanging fruits. And and someone who isn't on a lot of medicines, getting a good supplement history. is always good for elevations this big in the AST and the ALT, because things like green tea extracts can cause massive liver necrosis. There's a lot of substances and supplements that people don't know about. So if nothing ends up panning out for this person, that's kind of the last step. And often in like clot skin rounds, you hear the story of the med student going back and taking that history, and that's kind of the final diagnosis, is getting that piece of information. But really, in someone who has such a rich social history and a transaminase elevation this high, I think we're thinking infectious hepatitis at this point. We talked about viral, of course, generally sexually and bloodborne transition for this thing. So of course we're going to be sending the acute viral hepatitis panels, but really we need to broaden that for someone like this. I think to include non-viral causes of infectious hepatitis. Sounds like he only has one partner. Syphilis is very unlikely if there hasn't been any changes in kind of their relationship, but you can certainly test for that, and we've seen that on clat scan with in the form of Ben Chipkin's case. I think what joins the list otherwise, though, really like arbo infections and zoonoses do join that list. So, it's a guy out in the woods, a lot of ticks around. So certainly would be testing for ehrlichiosis, anaplasmosis. Lyme doesn't do it so much. Babesiosis is another good one. And you already did give some, I think you gave the basic metabolic panel, any sort of CBC cytopenia. If you see it like an anemia and a thrombocytopenia, we talked about this on a prior episode, that could point you toward these kind of tick-borne infections. It's often something seen in many of these. Rickettsial diseases you can think about too. Leptospirosis came to mind when you have like the very high bilies as well, and kind of the water exposure you were giving. I kind of saw like yellow in the water when you're talking about the boiling off. So I would be testing for lepto for sure. And for other zoonoses, you did mention he's like hunter. You said he's bears, and what was the other one?
Bears and deer, from what we got.
Got it. Okay. So tularemia is another one to consider in someone who's coming into contact. I can give a little information on that. Full disclosure, I'm just pulling up my illness script for this because I was actually reading about it the other day. But tularemia is a zoonotic disease caused by Francisella tularensis. And the syndrome you observe in tularemia depends on kind of how you acquire the bacterium. So if you are bitten by something like a tick, you can get kind of this ulceroglandular variant where you have like a local lesion and kind of like regional lymphadenopathy that's painful. You can, if you're touching animals and then you touch your eyes and your mouth and transmit it to your eyes, you can get this like painful red eye, and also pharyngeal disease. So if you literally like, hand to food contamination, you can get like sore throat and tonsillitis from that. If you inhale stuff, so if you're like mowing lawns and there's like a dead carcass around, you can get pneumonic tularemia. And then there's kind of this like non-specific variant that's called typhoidal, where we're not quite sure how people get it, but they had some exposure, and it's kind of like an FUO type of syndrome. So you can consider that causing some hepatitis if it's systemic. Acute fever is another one you can consider. Probably you're going to be testing for all of these things, just given the extensive exposure history. And, we're really doing that off the bat, I think, because the treatment is just going to be, we need to treat it. If he has it, he probably will get very, very sick if we don't treat it, and we just run under the assumption that it's viral, but the viral testing's negative. I think we need to figure out what's going on. But yeah, those are my initial thoughts. What happened next?
Wow, what a list! That was great. I'm going to give you the exam because I'm realizing now I forgot, and then I'll give you. I think I've got most of those tests for you. So he's a guy who, when he's not acutely sick with hepatitis, looks like he's probably pretty healthy. He's a robust, sort of muscular guy, of BMI probably somewhere around 22. He currently, though, looks to be in distress, and really the distress seems to be from the abdominal pain itself. not from work of breathing, and doesn't appear, doesn't. That's really why he's so in distress, is the pain. He really, the major finding is just the tenderness to epigastric palpation, and then he is bright highlighter yellow. So very, very jaundiced, and that's really it. He has a normal mental status. He's an excellent historian. He does not have asterixis. He does not have edema, no ascites, and lungs sound good. And he's on room air. And at this point now, he has actually had a fever to 101 Fahrenheit. But vitals remain stable. He was a little tachycardic during that fever, and it broke with some Tylenol after the Tylenol level was shown to be negative. So I'm going to then give you just the barrage of labs, and let me know if I missed anything, or if there's something you asked for that I didn't mention, because maybe we have it and I just didn't mention it. Okay, so his Tylenol level was negative. Ethanol on arrival was negative, followed with a PEth that was also negative. He has his Hep B is negative and non-immune. HCV antibody is positive, but the RNA is PCR negative ×2 actually. Hep A, IgM, and IgG were both negative, and we actually tested it twice just because with the water exposure, we felt like the pretest probability was pretty high. So we waited a few days, tested again, negative a second time. CMV negative, EBV, IgG, and IgM negative. We were in respiratory season, so RVP was also negative. We sent an HEV, which I think the IgG was positive, but the IgM was negative. RPR, you mentioned, was negative. HIV negative. And then anaplasma was sent negative. Babesia was sent and negative. Ehrlichia was negative. PCR and smear, both negative. Leptospirosis was sent and negative. We also sent trichinella, which was negative. And let me see. VZV negative, HSV1 and 2, both negative as well. And I'm going to stop there just because that was sort of most of the infectious workup. Let me know if there's something else you want, though. It's possible my eyes glazed over and missed one of these many labs I have written down.
Notice Mike tested for the HIV twice after the COVID AGEP case. We'll always test twice now. High pre-test probability, right? That's really great. Yeah, so we exonerated most of the things we talked about. The PCRs are pretty good for all these. I'm not sure if all those were PCRs. At least some of them were. Like I know the anaplasma and the Ehrlichia generally are PCRs. Because if the infection is very acute and came in early, IgMs can be negative because it takes some time for those to form. So that's another instance you would want to retest for something like that. But yeah, I think things were missing. If correct me if you did give this to me, because I think we're still thinking infectious either was missed on an IgM, and we're going to end up retesting if we don't have an answer in a week or two, and then probably empirically treat with doxycycline because many of these diseases are doxy responsive. I think that's one direction we may end up taking. The other direction is we need to complete the workup. And I think if this guy is hunting things, we really need the Francisella tularensis testing. And I think we also need the Q fever testing. While you were reading stuff off, I pulled up my Q fever script too. And I think hepatitis is a little bit more like classically described in Q fever. And usually that's more in like farmers, like around a lot of cattle where infected cattle, they get infection mediated abortions, and if that bacteria then gets aerosolized from like a windy day or anything else, that can be carried quite far. So even if he doesn't own cattle himself and he's not around kind of infected cattle, if he has some neighbors who do own a farm and those are infected, he could get infected from a downstream wind. So just because I think he's kind of remote, I would be testing for Q fever too, even though it's kind of not the classic story. I think it's more of like a tularemia type picture with like being around carcasses and and whatnot. It was brucella, I think, is another one we didn't test for. I don't have an illness script note for brucella, so I wouldn't be able to tell you too much. But again, since we don't have an answer yet, I'd be looking that up and sending it to see if that's something that we're missing. But otherwise, I mean, just to broaden even more, like other non-infectious parenchymal stuff. I mean, I guess you could run the history for supplements just to make sure we're not missing something. You can have a reactive fever to like hepatic necrosis, so the fever could be totally non-infectious and just a reaction to widespread liver necrosis, and that's just a red herring pointing us toward infection when it's not. So making sure we're not missing some sort of natural supplements that is containing something. We talked about the alcohol a little bit. The story doesn't fit because the transaminases are too high for that. And just in terms of like fulminant liver stuff, I mean, Wilson's is a metabolic thing that can happen. But I think again, it sounds like the AST and the ALT are even getting a little too high for that. A pro I learned on CladScan is if you have widespread hepatocyte necrosis, you get AST ALT like greater than 2000, like super high. But with the metabolic diseases, the hepatocytes really are destroyed by apoptosis, and that releases less AST and ALT. And the original number you gave me was up to 2000 for one of those. So I imagine it's just going to get higher and higher without treatment. So I'm not really thinking so much apoptosis and metabolic diseases. I'm really thinking more like necrosis from infection or other direct damage. But anyway, I'm excited to hear the case conclusion, Mike. This is a really interesting one. I'm sure your med students and residents really enjoy this, and no doubt the ID consultants too. It sounds like you probably got them on board with all of those ID tests. But what happened?
Those were great thoughts. We actually did not test for Q fever or tularemia um, or brucellosis because another test came back, and basically at that point which often is how these cases present, right? But really good thoughts, and like you said, if you're really worried about Q fever, I've not really read that much about brucellosis or tularemia, to be totally fair. But for Q fever, I feel that if you're worried enough that you're sending it, oftentimes you want to treat early with doxycycline even before you have that result back, because it has a lot of morbidity mortality without treatment. So very, very good point. I'll give you sort of the rest, and then see if any other thoughts, and then I'll give you sort of the final lab. That's okay with you? Okay, so like you had mentioned, this question of sort of like other causes of fulminant hepatitis, and then just kind of liver workup to even understand the risk chronically for him. So um, uh, we did send like the full autoimmune hepatitis workup, so which was negative. His ANA was negative, anti-mitochondrial, anti-liver kidney, anti-smooth muscle, all were negative. We did actually send a ceruloplasmin, which was normal, 41. And then thinking about sort of, are there things that are lingering under the surface that necessarily aren't causing a fulminant picture, but maybe are contributing to why he's getting so much sicker than someone who maybe has something that would otherwise cause a more mild presentation? So the alpha-1 antitrypsin was negative, or I should say normal, 189. But interestingly, actually, his ferritin is 4,600. His TSAT is 110, and the HFE gene was negative. And so just quickly, that was thought actually that possibly because he's only eating and drinking from iron, basically cast iron cookware for 50 years of his life, that he's developed sort of a secondary liver overload in his liver, probably, and maybe other places as well, because he just has so much iron consumption all the time, and probably also a fair amount of iron through his almost exclusively meat diet. So I thought that was interesting. Obviously not the cause of his presentation, but maybe he has some underlying iron overload in the liver that would predispose him to diseases that maybe otherwise would have a more mild course. Going to stop there, see what your thoughts are, and then I'll give you the final lab.
Oh shoot, I'm stumped. I think the other thing to keep in mind with iron studies in a patient who's having hepatitis, if there is true hepatocyte necrosis, which I think we're suspecting here, is probably the AST and the ALT are going up. The ferritin's going to be extremely elevated. It'll look like HLH or anything else that can cause a ferritin to be really high. This ferritin stored in the liver, so if you see ferritins climbing and you don't have an explanation, you often have to invoke cardiogenic shock that's been missed, or um, anything else that can cause kind of a fulminant hepatitis type picture. So I think that's just consequential to what we're seeing here, the very high ferritin. But I don't know what test is gonna come back positive. It sounds like it is a test. You can have seronegative autoimmune hepatitis, but it sounds like something did come back positive, and it's not going to be one of those things. But I would be guessing that it would be one of the infectious tests that either flips positive or you sent early on and finally came back positive, like a serologic test. But yeah, tell me, Mike, what happened? This is a really cool case.
Yes, I think we all expected that this was going to be infectious, but we retested most of the IgM studies. Specifically, EBV is, at least where I work, there's only serologies for that. HEV, excuse me, also only has serologies, so that was retested. Hep A, I already mentioned, was tested twice for the same reason. So, and they were negative a second time, and infectious disease was on board and felt that we can probably trust a double negative with a period of time separated. Um, the liver team, the hepatologists, are really who did a little more digging. Were able to find, I think, the piece that led to a test that we probably wouldn't otherwise sent. They, in the absence of an infectious cause, felt that there was likely some sort of toxic. This was a toxic exposure. Supplement history was done many times, kind of to the point where the patient is like, "Hey, stop asking me," and was negative. But interestingly, so the hepatology fellow, to his credit, actually looked at the map of where he lives, and maybe 10, 20 miles north, in the same river, is actually a I forget if it's a steel plant. It's a basically a smelting plant of some type of metal, and it looks like it probably at least dumps some wastewater into this river, and possibly with the rainfall, it may have increased the washout from this plant. And so we sent a heavy metal workup, actually, and we found that he had an elevated arsenic level, actually.
Oh, wow.
And arsenic is interesting. So it uh, basically, it depends on whether you're in an area where you're getting more of a constant arsenic exposure versus kind of the average person. So generally, if you work in a place where arsenic is a regular exposure occupationally, then you generally have testing of some regularity, and you're looking for the levels to be less than 50 in the urine. It's a urine test. In a non-exposed adult, it should be less than 35, kind of always. It has a relatively short half-life, so basically it should be, once you're a day or two out from exposure, it should pretty much be washed out. Within a week, it's undetectable by then, even with kind of a mild exposure. His level was 41, which sounds like it's not terribly high. It's a little bit over 35, but it's below that 50 of constant exposure that we look for. But this test was not sent for probably a week and a half to 2 weeks into this hospitalization. And so the thought was that for his level to still be elevated this far out from what would have been the last exposure, his numbers probably were quite high to begin with. And this is not a common presentation of arsenic poisoning. It tends to be something that causes more chronic issues. But at a high enough dose, particularly with sort of an acute exposure, there have been cases described of severe hepatitis, and it's treated like most other toxic hepatitis with N-acetylcysteine. So that is actually what he was treated with, and it took a long time, but it his hepatitis resolved on just N-acetylcysteine therapy for a period of time. And of course, things were filed to the
Wow, that's what a case. I think this is the perfect diagnostic arc for the episode though, because this guy had a lot of social exposures in terms of living in the woods that could have been infectious. And I really love how you all retested just to make sure that wasn't going on. Because if that was missed, that is something that certainly could have killed the patient. But arsenic, wow, I've only heard of that in the setting of India, where there are a lot of kind of natural cures that are unregulated. Like there's supplements in the US. The FDA doesn't have to investigate these over-the-counter supplements too. I'm sure that arsenic has happened here, but in India, there's a guy on Twitter. I think his name is Liverdoc. He's described this like numerous times, where these like Ayurvedic flasks contain very high amounts of arsenic, and he's described like children dying of acute liver failure from this. So if the dose was high enough in this guy could have died from that for sure. And that's why I believe arsenic was used as like an assassin's bullets back in the day. You can have someone drink it and they can just go into liver failure, all these sorts of things. But wow, to see that like just out naturally, what a case. That's crazy. And I think I mean, it does go back to, in terms of getting to that answer, the principle of severely elevated AST and ALT greater than thousands, very limited DDX. So again, the liver could be necrosing from frank ischemia. It could be the severely elevated pressures from the CBD obstruction, but generally that's transient and gets better. It could be infectious, which we exonerated here, or really like along the lines of Tylenol overdose, like toxic. So like just toxic injury where all of the hepatocytes are necrosing off. So kudos to whoever got that history. That is an insane story. I'm definitely not going to forget that. I'm going to have to add a heavy metal list, I think, to my list of testing for hepatocellular injury, because I definitely didn't have that on my list. So thank you, Mike.
Absolutely. Yeah, I feel like now, rather than just saying Tylenol, I think like toxin, of which Tylenol is almost certainly the most common. But thinking about toxic hepatitis as something that can push your LFTs into the thousands, rather than just thinking of Tylenol as the toxin.
Yeah, so good. But take it easy, Mike. Good to see you.
Great to see you as well. Thanks. This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us at dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.